Thank you, PCSI 2022 and Dr. Amitabh for giving this opportunity to be speaker. I'm sorry I'm not there physically and I have to do it online. So I'm going to speak on our experience about MISC, cardiac manifestations. There is no conflict of interest here. We all know these diagrams in 2022. The first half for 2022, 2020, there was all lockdown and the things. And with the second wave, especially when we all face a lot of number of MISC, and still we are seeing, though decrease in number, but still we are seeing. So starting with my case, it was in June 2021. It's a 1.5-year-old boy with history of fever for 3 days, redness, swollen eyelids, palm and sole edema with tenderness. These are the typical cases you all have seen as a pediatrician. The child was very irritable. It was so difficult to do echoes in these babies. There was history of COVID in the family 2 weeks ago. And his brother also had same symptoms, but of milder variety. The chest X-ray, there was lung infiltrates on the right side, quite significant. And this was the picture. Picture was taken with permission with the family. So there was palm, sole, edema, and eyes, puffiness, lips, red. So all features are sort of typical of the Kawasaki thing. So in the initial stage, the many names were given to the disease. Most of the time, they are having relative bradycardia and ECG with a junction escape rhythm. So this is the sinus rhythm going on, that there is absent P wave. So basically sinus node dysfunction with junction escape rhythm. This was quite common rhythm in these patients, and we had any sort of arrhythmia, complete heart block, first degree AV block, long QTC, STT wave changes. So many type of ECG changes happened in these babies in our study. Echocardiography, this is 4-chamber view. There was severe left ventricular dysfunction, dilatation, and there was a thrombus. So a patient, this is very unusual site for a thrombus to be formed, but we could see thrombus in L appendage, thrombus in left ventricle, thrombus in the right side of heart or the pulmonary arteries. These were the things which saw in these patients. So this baby had a thrombus with LV dysfunction and the dilated coronary arteries. Obviously, these coronaries were very typical of Kawasaki. The clinical picture was fitting into Kawasaki picture. Blood investigations, platelets were high, CRP was very high, there was relative anemia. TLC, DLC was normal with high BNP and drop high. Albumin was low, and he was COVID IgG positive with the negative RT-PCR. With this background, this diagnosis of Kawasaki-like disease or Kawasaki or MISC and then PIMS. So these were the names from KD-like picture to MISC were happened during that time. The child was managed in ICU with low dose of dopamine. CPAP was required because he was having respiratory distress and it was acute left ventricular dysfunction. He was given IVIG, and because there was thrombus, he was started on oral anticoagulant after low molecular heparin. And later, when the thrombus disappeared, he was continued on egosprin. On follow-up, 1-year follow-up is there. He's doing perfectly fine. There was no recurrence of symptoms and things, and all medication was stopped. Another case is a newborn. So with the LSCS was done for the fetal distress, loss of fetal movement, and there was thick mechanism aspiration. There was low FGAR on lower side FGAR, and with respiratory distress, desaturation, chest X-ray, cardiomegaly, echocardiography evaluation was done, and you could see severely dilated right heart. There was tricuspid regurgitation, and all these structurally heart was otherwise fine except PFO and the PDA. There was no outflow tract obstruction or the residual ventricoseptal or any large ventricoseptal defect. In short axis also you can see LV is just pinched, and it is dominating right heart in this patient. And ductus arteriosus was, this is a small PDA, which was shunting right to left, and that says the PA pressures are suprasystemic. So basically, this is severe pulmonary arterial hypertension in a newborn, born with the fetal distress, emergency cesarean section, and thick mucinum aspiration. So everything fits into PPHN. With PPHN, you need a supportive care from PPHN point of view, but because this scenario was going on, we had to think from the additional entity which was happening there is about the COVID inflammatory response. cultures was negative, reducing platelet were there, because in PPHN, as such, you don't expect a high CRP or falling platelets. Then these additional things were there. We have to think for the another infection or inflammation thing going on. Coronaries were dilated, so TLC was high, platelet were borderline, CRP was very high, and it was very fast rising from day 1 to day 3, 4. It was from 10 to 116. So it was a very acute rise in the CRP in these patients. Mother was COVID positive, and with that background in mind, with the whatever was going on with cases being reported, so IVIG and methylprednisolone was added to the with the new entity MIS, and basically MIS fetal MISC leading to neonatal manifestation. This was the scenario happened with these baby, and you can see the chest X-ray. So first X-ray was huge cardiomegaly, and here with the response of with IVIG, 3 days after, CRP was 10, X-ray was almost normal, echo PA pressures was almost normal, PR was 22 on 3rd day of IVIG. So this dramatic response can happen only when something additional inflammations can't be explained by PPHN only. That doesn't go so fast. That take time. But inflammation, obviously, we suppress the inflammation by the anti-inflammatory drug, and child did very well, that newborn. So with that, the first, the case report, the first entity was reported in 2022. And in that, at that time, it was initially thought that children are immunologically less susceptible to COVID. So we sort of that it is disease of adults. Kids are minimally asymptomatic. So it's sort of false thing was going on in our mind. Kids are comparatively either less susceptible or less symptomatic. But with this MISC, that was an alarming situation. Initial study shows 1% of the babies with COVID had MISC. And they said it was the older kids' involvement. And according to that study, it was basically myocarditis. You may have myocarditis with shock, with CHF, or just ventricular dysfunction with high BNP and anti-pro-BNP, or echo normal but high inflammatory markers. So all 3 manifestations, all 3 type of presentation could be there in these patients with multi-system involvement, with inflammatory syndrome with the COVID. Our experience of about 111 babies, and we compared the data with the recent publication in Circulation in 2021. So our data-wise, the cardiac involvement who were referred to us for me for echocardiography with the suspicion of MISC by the pediatrician. So there was symptomatic, the child was symptomatic, either bradycardia or infection or fever. All lab reports were, and all were COVID antibody positive. None was RT-PCR positive. So in all patients, they were suspected to have MISC, strong suspicion of MISC by the pediatrician, referring pediatrician. The cardiac involvement was almost always there, 95%. Cardiac dysfunction around 40%, which was in tally with the published literature. Coronary artery involvement, around 2/3 of patients were having coronary artery involvement. It was either dilatation or aneurysm or thickness of wall, brightness of wall. Many types of changes were there in these patients. Diastolic flow reversal, it is not reported in the literature, but in 17% of patients, it was with severe left ventricular dysfunction, low cardiac output, we see diastolic flow reversal. But comparatively normal left ventricular function, having diastolic flow reversal alarm us towards that some sort of vasculopathy, arteropathy is going on these patients, and they are on follow-up with us. Pericardial effusion, almost 50% of patient. Mitral regurgitation, mild TR is quite common in general population, but MR more than mild is not something benign thing. So we had almost 50% of patient had either mild or more than, none had severe, but mild moderate MR was there. Aortic regurgitation in around 1/5 of the patient. Intracardiac thrombus in around 2% of patient. Pulmonary hypertension, mainly newborns, were in 10%, and rhythm abnormality in 6%, which is reported in 6 to 25. So many things which were not reported, which noted in our study. And the correlation with the statistics showed that there was no significant association between duration of admission, duration of illness, basically, age of patient, BMI, BSA, with coronary artery dilatation and dysfunction. So this was anybody can have severe cardiac involvement. There were no association with the fever of 1 day or 10 days or 3 weeks. We had seen coronary involvement and ventricular dysfunction and thrombus formation. So we could not find any direct correlation with that. And thus, there was no significant direct correlation with level of inflammatory marker in these patients. So inflammatory marker very high, we may see normal cardiac patient. Inflammatory marker mildly elevated, it did see significant cardiac involvement. So inflammatory marker and cardiac involvement plus type of presentation, clinical symptoms and cardiac involvement, there was no definite correlation, but they all responded to anti-inflammatory medication. That is the important thing. So coronary artery dilatation was commonest being the left main, then LAD, then RCA, and least common involvement was the circumflex artery. So this picture is showing, this is right atrium, left atrium. This is big thrombus sitting in a right atrium in this patient. This was 1.5-year-old child with MISC and cardiac response to the on follow-up. So initial coronary chamber dilatation, floor ventricular dysfunction, everything was there, but on follow-up, everything came down. This was 1 month follow-up post anti-inflammatory therapy. Cardiac MRI, the study is going on various centers about the long-term effect of MISC on cardiac. So cardiac MRI is being done. This is one of the patients who had MISC in neonatal period and now having the fibrotic changes into the myocardium. But in majority of patients, this permanent scarring is not seen in post-MISC patients. So that is a good finding. That says that it is sort of acute insult responded to anti-inflammatory and long-term, not in majority of patients, but in some patients. So a follow-up is important by echocardiography, by ECG, clinical, and then if you have a doubt, we need to ask for the further modality like the MRI. In our observation, the difference between MISC and Kawasaki disease is MISC we could see at any age, even 15, 14 years, starting from the newborn, or you may say fetal, we could see MISC. Kawasaki has its own defined age. Neonatal involvement, obviously not much known about the Kawasaki. Shock is more common here. Disproportionate clinical presentation. As told, the symptoms and the cardiac involvement, it was quite disproportionate about the symptoms and about the inflammatory marker. In Kawasaki, we see high inflammatory marker. The clinical picture most of the time explain our cardiac findings. Cardiac involvement is very common as in comparison to Kawasaki disease. LV dysfunction is more common. Coronary involvement is higher, which we see in our study and in other published data. Intracardiac thrombus with normal EF also reported in MISC, which is not in Kawasaki disease. Rhythm abnormality is more common. Prolonged QTC, AV block, any type of rhythm abnormality is seen with MISC, not that with the Kawasaki disease. And diastolic flow reversal, there are few with shock and poor LV dysfunction with Kawasaki disease, but here with MISC, even with normal functioning heart, so-called, we could see diastolic flow reversal in aorta that points towards a arteriopathy, and obviously we need a long-term follow-up to look what is happening. And this is our analysis about the MISN, about the COVID, post-COVID multisystem inflammatory disorder, where we could see, even in newborn, we could see cardiomegaly, PH, mitral regurgitation, aortic regurgitation, pericardial effusion, thrombus, so all sort of involvement also being reported in newborn. And the good thing, at the time of suspicion of the disease, the CRP was so high, and within 3 days, the response to IVIG in these patients was really beautiful. So that means early pickup of the patient and early treatment help these patients. In last, I would like to show the recent encounter with MISC. So this is older kid, 11-year-old child with history of fever for 3 weeks. It was high-grade fever, 100 to 102, and he was hospitalized somewhere, received antibiotic, IV antibiotic for 2 weeks. There was no response. TLC was within normal limit. Platelet were lower side, 80 to 1000. There were multiple reports. CRP was very high, 80 to 120. A walk-in patient with this CRP, I always keep a possibility of MISC. Cultures were negative. Other fever causes, malaria, dengue, typhoid, everything was done and it was negative. And the last thing was COVID antibody positive with negative RT-PCR. And he was also carrying a normal echo report from outside. Positive finding, except everything normal except mild pallor plus wide pulse pressure. So BP was 110 by 30, and my residents were very worried about his blood pressure. ECG, he was carrying the ECGs, and you could see it was 1:1 AV conduction, heart rate on slower side, child who is having a significant pyrexia. So PR interval was progressive from day 14, day 12, 160. Normal, we expect at this age up to the 100, 110. So 160, 200, then 280. In the same day, 200 to 280 his PR interval. When we saw the child on 28th day, it was 280 with 1:1 AV conduction. Rest of the intervals were normal. And this was the echocardiography. Contractility was good. There was a small pericardial effusion and his coronaries were normal. There was no intracardiac thrombus, no vegetation, no other structural heart defects. So he was treated as MISC. It was in government setup. Finances were issued. We gave methylprednisolone high dose and started on ecosprin. 3 days post ecosprin, 2 days, the PR intervals of 140. So in today's scenario, all pyrexia of unknown origin we should keep MISC as a differential diagnosis. They can come in any form. This prolonging PR interval was a manifestation here, and when you do echo, you just find some pericardial effusion, which is very non-specific. But rhythm abnormality gave us an direction to think towards the MISC, and the response was really good. So take-home message is cardiovascular involvement is nearly universal. We are seeing less patients now, less coronary involvement, but we are still seeing. So need to have a suspicion towards this in all patients with atypical presentations, not usual patients' presentations. This could have myriad presentation, extreme age group, spares none, even fetal, newborn, or any age group are affected. And we are seeing 40, 50 year of age with sudden death, so many causes. So probably we are missing them, that multi-system inflammatory involvement was there in those also at some point of time. Need to have a multidisciplinary team. Long-term outcome is unknown, so long-term follow-up is needed. We have given IVG and IVIG and steroid. Some patients received both. Some patients received only IVIG, and some received steroid. So had a learning curve. Now today, the choice is IVIG, but a big number of patients can't afford IVIG, so we go towards methylprednisolone, and the outcome is almost same in all patients. And this paper is under publication about our study on MISC. Probably this is underreported thing, and we have to have centralized data collection. All patients should be reported, and planning about the management and long-term follow-up is important. Telecardiology today, like ECG, can be done anywhere. Screening echo can be done anywhere, and if suspicion, specialized opinion should be taken all these patients to help to make them better, to have a very good outcome. The disease which respond as of now responding to the treatment what we are offering to them. Thank you.